webinar. My name is Frederick Shaw, and I'm the acting editor of Public Health Reports, or PHR, the official journal of the U.S. Public Health Service and the Office of the U.S. Surgeon General. The PHR Meet the Author webinar series is presented to stimulate discussion around current topics in public health. For today's webinar, titled Progress in Women's Health 1985 to 2015, we have as speakers three federal government leaders in women's health who will discuss both achievements from the past and challenges for the future. And this was a topic that was featured in the March-April 2015 issue of our journal, Public Health Reports. On behalf of U.S. Surgeon General Vice Admiral Vivek Murthy, I want to thank Dr. Nancy C. Lee, Deputy Assistant Secretary for Health, for Women's Health, Director of the Office of Women's Health at the U.S. Department of Health and Human Services, Dr. Janine Austin Clayton, Director of the Office of Research on Women's Health, and at the National Institutes of Health, HHS, and Ms. Marcia B. Henderson, Assistant Commissioner for Women's Health at the Food and Drug Administration, HHS. I'd like to thank them all for joining us today. Our presenters will describe progress on women's reproductive health, understanding of sex differences in medicine, and the inclusion of women in clinical research. The ultimate goal is a nation where women can prevent morbidity and mortality from disease, and where quality care and health equity are a reality for all women. Just to note, this and all PHR webinars are archived on the PHR website for future viewing, and a question and answer session will follow today's presentation. To submit a question for after the presentations, type your question into the chat question box, which is opened by clicking the small white arrows that are in the upper right corner of your screen. And by the way, if you're interested in seeking credit for certification in public health, continuing education, practice instruction, you'll be given a password at the conclusion of the webcast. So now it's my pleasure to introduce Dr. Nancy Lee, Deputy Assistant Secretary for Health and Director of the Office of Women's Health at HHS. Let's begin our presentation. Welcome, Nancy.
Thank you, Dr. Shaw, and the Public Health Reports Journal for the opportunity to talk about progress in women's health in the last 30 years. I am pleased to be joined today by Dr. Janine Clayton from NIH's Office of Research on Women's Health and Marcia Henderson from the FDA's Office of Women's Health. I know you will appreciate their presentations about progress in women's health research and how that progress has led to advances in drugs and medical devices for women. Today, I'd like to begin by taking a look back at how far we've come in the last 30 years and where we might go in the future. Next slide. This year marks the 30th anniversary of the landmark report that helped put women's health at the forefront of biomedical research, medical practice, and community health. In 1983, the Department of Health and Human Services convened the first ever task force on women's health issues. The 1985 report out of that task force focused all of the key stakeholders, researchers, policymakers, pharmaceutical companies, and healthcare providers to better recognize the need to focus on the health of women across the lifespan in the context of their everyday life. This report helped propel women's health to a new realm where we could practice something beyond what I like to call bikini medicine. A woman's health involves more than just her reproductive functioning, more than just what is covered by her bikini. Next slide. Specific health conditions behave differently in women than in men, and this goes down to the very cells that make up a woman. For example, we know that often a heart attack in a woman does not look the same as a heart attack in a man. Women are more likely to experience non-traditional symptoms of a heart attack, such as shortness of breath and an upset stomach. Women are older, on average, when they experience their first attack. And women are more likely to die after a heart attack compared with men. We definitely need to do a better job of treating women during and after their heart attack. Even the effect of aspirin for heart disease prevention is different between men and women. The U.S. Preventive Services Task Force recommends that men begin at age 45 to use aspirin for cardiovascular disease prevention, but that women shouldn't start aspirin until age 55. Next slide, please. While it would be impossible to list all of the advances in women's health in the last 30 years, what you see here are some of the areas where there has been great progress since the HHS Coordinating Committee on Women's Health was first convened in 1984. You can see more details about these achievements by going to our website at womenshealth.gov and searching on the phrase 30 achievements. The website address is at the bottom of this slide. There you will find an interactive display of the achievements plus a timeline that includes many more advances in women's health. I'd like to call your attention to a few notable things from this list. They're in a lighter blue. One is the increase in women's lifespan, which has been driven in large part by fewer deaths from cancer and heart disease. More women are getting screened for cancer and fewer women are smoking. We've made tremendous strides in caring for women with HIV and AIDS. Not only are women living longer with HIV and AIDS, but due to treatments funded by research from the National Institutes of Health, we have lowered the risk of a mother passing HIV to her baby to less than 1%, ensuring the health of a future generation. And women today have an array of safe and effective methods of birth control, including emergency contraception. There has even been an increase in the use of the highly effective long-acting reversible methods of contraception, such as implants and IUDs. The FDA has played a key role in reviewing and approving these drugs and devices, and also in removing drugs and devices from the market when they present a danger to women. You will hear more about that from Marcia Henderson later on in the webinar. Next slide, please. Today, the Office on Women's Health works to see that all women and girls achieve the best possible health. The office was first created in 1991 to advance and coordinate a women's health agenda throughout HHS. With a truly comprehensive perspective on women's health, firmly rooted in the healthcare landscape, we work with partners from all sectors to promote the health of women and girls. Next slide. We do this through policy and model programs and educating the public and providers. We focus on helping women and healthcare providers fully utilize the coverage and services provided under the Affordable Care Act by supporting efforts to reduce violence and trauma for women and their children, by increasing their health across the entire lifespan and reducing health disparities. Next slide. We accomplish many of these goals by connecting with women through the online platforms they are already using. We have almost 1 million followers on our Twitter channel, so after the webinar, please check us out on the web or on the social media platform of your choice. Next slide. While the overall health of American women has improved since the release of the 1985 report, not all women have benefited from these advances. Because serious health disparities exist and persist, we need to understand the social, cultural, and economic factors that shape health outcomes for women and then work to improve those outcomes. Groups facing these health disparities include the disabled, immigrants, the poor and uninsured, women of color, and those living in rural America. While we know that women's health is more than just reproductive health, her health before, during, and after pregnancy is vital. Expectant mothers today are more likely to be older, heavier, or to have a chronic disease such as high blood pressure or diabetes. And since 1987, the rate of pregnancy-related deaths has more than doubled. Much needs to be done to improve the health of moms and their babies. In the United States, 50% of pregnancies are unplanned, despite the availability of multiple types of safe and effective contraception. And there has been little improvement in this statistic over many years. In OWH, we are working to make sure that women understand that a woman understands that reproductive service is available as a result of the Affordable Care Act so that she can plan her family and ensure that each of her children has the best possible health outcomes. The obesity crisis affects us all, men, women, and children. The increase in obesity and sedentary lifestyle in U.S. women over the last 30 years has long-term and serious health consequences. This is another area where policymakers, government leaders, and communities need to work together to create environments where it is easier for women to make healthy choices. 1 in 4 women experience intimate partner violence in her lifetime, and many of these women experience poor health outcomes as a result. We need to more effectively prevent, address, and eliminate this social ill. Finally, unless we forget, in 2002, an HHS Women's Health time capsule was buried on the NIH campus containing more than 70 items and publications commemorating major improvements in the health of women during the 20th century. Items in the capsule included a mammogram, a pack of oral contraceptives, a female condom, and an exercise videotape. The capsule should be opened in the year 2100, and to ensure it can be found, it is registered with time capsule organizations, which have its satellite coordinates. I'd like to thank again Fred Shaw and the Public Health Reports team for this great opportunity to share with you the progress we've made in women's health in the last 30 years and the challenges that remain. And now I have the honor of introducing Dr. Janine Clayton, the Director of NIH Office of Research on Women's Health. Dr. Clayton is going to discuss how sex and gender differences matter at all points in the biomedical research continuum. Dr. Clayton.
Thank you, Dr. Lee, and thank you to the organizers for allowing me to participate in this session. It's truly an honor and a privilege to be able to share this information. Next slide, please. I'll be talking to you a bit about the NIH Office of Research on Women's Health, where we've come from, where we're going, and the challenges that face us today. And this slide shows you some of the key figures, and women and men you'll see in the next slide, that have paved the way for the work that we do today. Actually, I wanted to share with you that the NIH Office of Research on Women's Health is now in its 25th year. We're founded in 1990, and in 1991, the Women's Health Initiative was started. That was under the leadership of Dr. Bernadine Healy, the then and only female director of the National Institutes of Health, and at that time, Dr. Vivian Pinn, the first full-time director of the Office of Research on Women's Health, was in place. So we started out with an amazing and incredible effort from the very beginning. In 1993, NIH began its inclusion policy, which mandates the inclusion of women and minority groups in all NIH-funded clinical research. So we heard from Dr. Lee about some of the issues around women's health, and we're shifting gears here to talk about how critically important it is that research, scientific investigation, actually leads to benefits in our health. And so we'll fast forward from 1993 to today in 2015, where the NIH Office of Research on Women's Health represents the focal point at NIH for research on understanding exactly how sex and gender factors influence health and disease. That way of thinking benefits boys, girls, men, and women. And so the visionary leaders that resulted in the report of the Public Health Service Task Force on Women's Health Issues brought research to bear at the very beginning, and they've highlighted conducting research and evaluation as one of the recommendations. Next slide, please. And as we are today at NIH in terms of our mission here as part of the Department of Health and Human Services, put in a nutshell, what we do here is turn discovery into health. In order to generate that discovery, basic research on human health and disease has to be the foundation. That research has to be translated through translational research and into the patient in clinical studies. And of course, we need to support and train the biomedical workforce that does all of this research. NIH funds 4,000 institutions, small businesses, over 300,000 scientists and research personnel and trainees. All of this is done in partnership with universities, the public, and industry. Next slide, please. And what's the benefit of that research? Well, let's just take the Women's Health Initiative, or WHI for short. This was a $250 million clinical trial, and other studies were embedded as well. But what I want to highlight for you here is that initial investment resulted in $37 billion net economic return in the past decade. So the $250 million might sound like a big figure, but $37 billion is a lot more. More importantly, what that did for us learning about how hormones can affect women postmenopausally when they're administered for menopausal symptoms was that we spared 75,000 women from developing heart disease. We also prevented 126,000 cases of breast cancer, and we added 145,000 quality-adjusted life years overall. So that's really what we're about. Next slide, please. As we go into 2015, what we share on the web and in other venues is the fact that sex and gender, we'll talk a little bit about the fact that they are not the same, how they influence health and disease. And I want to highlight for you one of the resources on our website. It's the ORWH, or Office of Research on Women's Health, A to Z guide. And here we highlight sex and gender influences on health, from cancer to alcohol use to smoking. There are many, many ways that both sex and gender affect health, and I encourage you to take a look at that website. It's easy to get to from www.nih.gov/women. Next slide, please. And so what about these terms, sex and gender? I want to make sure that all of our listeners and attendees feel comfortable understanding that those terms are not the same. In fact, when we use the term sex, we are really talking about the biological makeup of males and females. In fact, every cell in a woman has a sex, a female sex, and has a karyotype of XX, and every cell in a man has a sex of XY. So your liver cells, your lung cells, your skin cells, your heart cells, they all have a sex and correspond to your sex. And sex begins in utero. So from the very beginning, when tissues are just being formed, they have a sex, and that influences how those tissues develop. Sex affects behavior, but gender also affects behavior. And when we say gender, we are talking about behavioral issues. We're talking about the perception a society may have or a culture may have on what is a masculine or feminine behavior a person may have of their own behavior. It is imbued with social, cultural, and environmental context. You may hear the terms feminine and masculine used when we're talking about gender. It's truly a continuum, whereas sex denotes the genetic, molecular, cellular, and physiological differences between being male and female, and that is a binary. It's either male or female, barring any disorders of sexual development. Next slide, please. So in 2015, the way we are approaching at the National Institutes of Health these issues is thinking about this beyond inclusion. Certainly, we do need women and minorities participating in clinical research in order to answer questions that are relevant for all the individuals that are affected by a disease and condition, but we need to do more than that. We have to start from the very beginning in our preclinical studies, those basic science studies in the laboratory where we're using cells or animals or tissue culture or other basic science laboratory techniques to learn about the pathophysiology, the causes of a disease, or to understand basic biology, female and male biology. So we have to think about sex there. We also have to think about it as we initiate our clinical trials. So the earliest phases, phase 1 and 2 trials, we have to think about the fact that males and females respond to treatments differently and may have different safety profiles related to both preventive and therapeutic interventions. And then phase 3 clinical trials, clearly when we're trying to really push and understand whether a treatment is effective for males and females, we've got to include enough women and think about how we design that study to answer the study in a way that's relevant to males and females, in the way the disease presents in males and females and related to safety concerns. And then, of course, in phase 4 clinical trials, we learn even more, especially about low event rate or uncommon side effects. More importantly, even if we do all of this work, unless we report these analyses and the data in a sex disaggregated way so that we can see the results for males, the results for females, and we can compare to see if they're different or similar in scientific journals, in publications, and reports, all of that work is for naught. So it's critically important that that gets disseminated as broadly as possible and in that way. Health policy clearly is based on research and evidence, health education, and health care, which is the ultimate goal here in order to deliver the best quality care to every single patient that each and every one of us deserves. Next slide, please. Along those lines, NIH has been addressing some of the concerns that have been raised about the fact that there have been challenges in reproducing, replicating, doing the same experiments over and over, and finding that some scientists could not match the results that were found and reported by other scientists. And Dr. Collins and Dr. Tabak reported last year that in the case of preclinical research, again, that's that laboratory research that we really need as a foundation for clinical research in people. But in that preclinical space, some of the design elements that we often take for granted in the clinical space, like randomization or masking, or making sure we have enough of a sample size to test the effect for which we're looking, and even the effect of sex differences are not thought about in that preclinical research space. Next slide, please. So NIH has been addressing these issues, and Dr. Collins and I published a piece in Nature in May of last year where we talked about the fact that we'll be calling on investigators to account for sex as a biological variable in their preclinical research. And we know that in the clinical space, where we now have for NIH-supported clinical research, over 50% of those participants are women. We know that took a concerted effort to get to that place. And so we're saying today we're going to have to focus on the preclinical space and take on a balanced approach to making sure that we're addressing sex as a biological variable and incorporating that perspective. Next slide, please. In order for us to achieve our mission, which I talked about a few slides ago, we absolutely must incorporate sex, which is a biological variable and probably one of the most fundamental biological variables, and we have to study both sexes. In order to turn discovery into health for humans, we absolutely must do that. Next slide, please. We certainly cannot do that alone, and enhancing the study of male and female biology in that preclinical research takes a village. We've got to work together, and we're excited about that opportunity of working with so many different partners and stakeholders to do this. Scientific progress has been emerging from our NIH-funded laboratories, and I'll tell you a little bit about that in a second. There's clearly increased congressional interest and support for the notion of making sure that we study males and females at a most basic level as well as in the clinical space. Journal policies, again, they're critical gatekeepers. They control what comes out in the public space. Journals have now embarked upon improving reporting standards, and they're asking for more information about sex of cells and animals to be included in the publications. And as you know, there's a developing policy that NIH is developing, as I mentioned, for considering sex as a biological variable in preclinical research. In addition, materials are being made available for the scientific community and for the public to help us understand how to exactly do this and what this means. Next slide, please. So last year, and we talked about, for the past 2 years, in fact, the Office of Research on Women's Health has partnered with every single available institute and center to fund administrative supplemental awards, which is existing grants. We've allowed investigators we've provided them additional funds to apply a sex and gender lens to their research. By this mechanism, we're facilitating, maximizing the return on investment of our existing resources and actually asking people to think about their own research in a different way. So we are really thrilled about this, and we're excited that we're addressing a lot of different disease-specific areas, which on the next slide you can see. The next slide shows the various disease areas that are addressed in these supplemental awards, and just shows that really we can do more, and we can see more, and we can discover more and learn more when we study both males and females. And we're covering cardiovascular disease, pulmonary disease, substance abuse, neurologic topics, muscle and bone, mental health, virtually every area of research covered by NIH is being supplemented in this way. So we're really excited to see the scientific advances that will be coming out of these awards. The next slide, please. One of the other areas that I'm particularly excited to share about is a partnership that we have had for many years with the Office of Women's Health at the FDA, and that is the Science of Sex and Gender and Human Health online course. There are 3 modules in this course. They cover both basic science and clinical investigation and offer a variety of continuing education credits for various fields, including medicine, nursing, and pharmacy. And the newest module, Module 3, is entitled The Influence of Sex and Gender on Disease Expression and Treatment. And there you can learn about sexual dimorphism in bone diseases. We can talk about the fact that heart failure is a particular pattern of cardiovascular disease that has unprecedented import and effect on women that we need to continue to address and improve upon. Sex and gender influences in pulmonary function and health, in the nervous system, and in substance abuse and treatment. The next slide, please. So I encourage you to take a look at that. Thanks. This slide shows a special section of the ORWH website, www.nih.gov/sex-in-science, and this is a site that we call Studying Sex to Strengthen Science, or S4 for short. Here we are highlighting in one place many different resources that are available to the public to help explain why our goal is to transform how sex is done, so that men and women can get the full benefit of scientific research and the medical advances that we need. You'll see training resources here. You'll see videotapes and slide sets from a variety of events, including a workshop that we hosted last year on the methods and techniques for integrating the biological variables of sex into preclinical research. You'll hear from investigators in their own words about their own science. So I encourage you to take a look at this exciting website. The next slide highlights and summarizes the major points that I want you to take away with you from the end of my presentation here. I would like for you to remember these 4 C's of studying sex to strengthen science. In virtually anything that any of our listeners may be doing that is relevant to human health, this perspective can maximize how much you can learn from what you're doing. First, I want you to consider sex as a biological variable, and think about it when you're designing your studies, when you're initiating a literature search, when you're thinking about a research question, when you have a patient in front of you. Think about whether being male or female is being taken into account, and if not, why it isn't. If you're doing a study, we want you to collect that information by sex and tabulate it in a sex disaggregated way so that you can characterize your findings in the context of sex. You can tell us about what you found in males, what you found in females. You can compare and contrast those findings. You can talk about similarities and differences, and you can analyze that data based on sex as appropriate for the particular scientific question and the context. And most importantly, we want you to share information, sex-based data. We want you to report it. We want you to publish it. We want you to talk about it. It's very, very important that we all take up each of our roles and responsibilities in this space, and I think together we can learn so much more about what sex and gender mean for health and disease. Again, thank you to the organizers, next slide, for inviting me to participate in this session. Here you'll see some resources that are available. It's certainly my pleasure to have been here and to work together with such fantastic folks to advance women's health. Thank you. The next presenter is Marcia Henderson. Marcia Henderson is the Assistant Commissioner for Women's Health and the Director of the Office of Women's Health at the Food and Drug Administration. Dr. Marcia Henderson?
Good afternoon, and thank you for this opportunity to talk with you today about the Food and Drug Administration and the vital role it plays in women's health each and every day. Over the last 30 years, FDA has created the Nutrition Facts Food Label, established standards for quality mammography services, approved the first drugs to treat HIV, osteoporosis, and Alzheimer's disease. We've developed a method to analyze lead in lipstick, and we've revoked approval for harmful diabetes, arthritis, and surgical implants. Next slide. And why do we do this? We do it because we are the oldest consumer protection agency in the government. For over 100 years, since 1906, FDA has been protecting and promoting public health. Our responsibilities have changed dramatically over this time, often in response to public tragedy as well as scientific discoveries. so that today we regulate over $1 trillion worth of products, about 25 cents of every dollar spent annually by American consumers. Next slide. As part of our consumer protection role, FDA regulates a wide array of products, drugs, both prescription and over-the-counter, vaccines, blood and tissue products, medical devices and diagnostic tests, all food except meat and poultry, cosmetics, veterinary products, radiation-emitting products like microwaves and mammography equipment, and tobacco. We're also responsible for product labels and conducting inspections. And as a scientific organization, we base all of our decisions and information about these products on results from clinical trials. The development of drugs and medical devices follows well-established paths to make sure that they are safe and effective when they reach the public. From concept to approval and beyond, FDA reviews research data and information about these products before they are available to the public. We watch for drug problems once drugs and devices are available to the public, and we monitor the information, advertising, and quality of the product. Next slide. Clinical trials, as you know, are voluntary research studies conducted in people and designed to answer specific scientific questions about the safety and effectiveness of our drugs, vaccines, and therapies, or new ways of using existing treatments. It's important to remember that FDA does not conduct clinical trials. FDA reviews clinical trial data submitted as a part of a product application. And we are interested, therefore, in the patient or population's characteristics that might impact the safety or effectiveness of the product. So we look at a range of variables: sex, age, race, ethnicity, disease stage, comorbidity conditions, as well as disability. In order to have accurate information about the end user of these products, FDA works to make sure that people representing these different backgrounds are included in clinical trials. Next slide. In 1994, the Office of Women's Health at FDA was created. It was in response to a GAO report that said women were not adequately included in clinical trials and that there was a lack of understanding about sex and gender differences. At that time, FDA had regulations that said, quote, women of childbearing potential, end quote, should not be included in clinical trials. Part of this was due to early tragedies from products like thalidomide and DES. Once the 1992 GAO report was issued, women's health advocates lobbied Congress. In 1993, Congress mandated that FDA establish an Office of Women's Health, and our office was actually staffed in 1994. Next slide. Our new mission was to protect the health of women by doing three things: to promote testing of products to learn their effects in women, 2, to educate women and health professionals with information across the lifespan, and 3, to engage our FDA colleagues and external partners to increase the number and analysis of women in clinical trials. And I am pleased to report that we have made a difference. Next slide. Progress has been made, and in 2001, a GAO report found that women were a majority of the clinical trial participants in the new drug applications that they examined. They stated that clinical trial participants in these new drug applications that it examined included enough women in the pivotal studies to be able to statistically demonstrate that the drug was effective in women. In 2011, our office conducted our own research, and we did a study of 47 clinical studies included in new drug applications, as well as biologic license applications that had been submitted during the 2010 period. And we found that from these products that used both men and women, 54% of the subjects were women. And there is a white paper on this assessment online on our website. Next slide. Our office has used our funding to support approximately 300 research projects. The bulk of the projects, which are intramural projects, have looked to answer the question, what is the regulatory question that we need to answer? And we have used our funds in such a way that they are arrayed on this slide, indicating that our #1 priority has been cardiovascular disease, followed by cancer and pregnancy. Next slide. To better address research questions important for regulatory decision making, we are building a new research roadmap, and it will allow us to better plan, coordinate, and fund our activities. We have evaluated our existing research findings, asking the question, what have we learned? And we have reviewed the FDA center priorities and developed a gap analysis to look for future opportunities. So the new OWH research roadmap will be a strategic plan, and we will be posting that new plan on our website this summer as part of the requirement under the FDA Section 907 Action Plan. Next slide. Many of you already know that we have a congressional mandate under the FDA Safety and Innovation Act. The act requires that FDA address to what extent our clinical trial participants are sufficient to determine safety and efficacy by demographic group for the submissions of product applications to the FDA. In 2013, FDA issued a data report that found that progress has been made because 72 applications across all areas, drugs, biologics, and devices, for 2011 included enough women to adequately represent safety and effectiveness decisions for FDA-approved products. Analysis by sex in clinical trials are now almost always done in these new applications. But there is still room for improvement. Trial participants are still predominantly Caucasian, and we also found that the numbers for women were lower than we expected in the areas of cardiovascular disease, HIV, and COPD. So yes, we have a lot more work to do. Next slide. Consistent with our mandate, we are working to educate health professionals. As Dr. Clayton mentioned earlier, we have a course that focuses on the science of sex and gender in human health, and it offers approximately 17 credit hours for those who take all 3 courses. We also have a new curriculum and toolkit that we developed with the American Association of Colleges of Pharmacy for over 220 schools of pharmacy across the country. Next slide. In addition to educating health professionals, we have made a major effort to educate women where they live and work, using our easy-to-read and culturally appropriate fact sheets, brochures, and videos. They are all available to order. Some of them are in many languages, and we will ship them to you for free. Next slide. We also have what we call special projects for special populations. Some of them include pregnant women, college women, women with disabilities, just to name a few. Next page. Next slide. All of this information may be found on our website, and we hope that everyone knows about our website, but for those who need a reminder, we use other approaches to reach women with this health and safety information. We bring them into our website with digital media alerts, via Twitter, blogs, and web ads, and we also do publication promotions and videos. Next slide. So we invite you today to join the conversation on diversity in clinical trials and to spread the word about FDA resources. Next slide. In closing, I'll simply say, here are our key resources, and they have been designed just for you. I will now, in closing, turn it back over to Fred.
Thank you very much, and I want to thank our three great speakers, Dr. Nancy Lee, Dr. Janine Clayton, and Ms. Marcia Henderson. Those were really great presentations. We will now take questions from our audience. You may type your question for any of the authors into the chat or question box in the right-hand corner of the screen, and you can open the box by pressing the two arrows. Erin?
Thank you, Dr. Shaw. And we have a first question, and I believe it is appropriate for the entire panel. So panel, if you would like to chime in. The question is, how difficult is it to get female subjects for clinical studies? Panel?
Well, this is Marcia Henderson. Our data indicate that women are very willing to participate in clinical trials. We've taken quite a look at this, and one of the things that we found is, of course, women may need some additional supports. They may need some help with child care or transportation. But one of the things that we know we can do at FDA, and we're trying to really focus on this, is to look at some of our exclusionary criteria. One of the things that FDA does is review these applications, and we're now beginning to think that some of the criteria may be influencing whether women participate. So, for example, for cardiovascular disease, where we know that women present with this condition at older ages, it may be that it's not appropriate to cut off participation at, let's say, the age of 55. It may not be appropriate to disqualify someone who may be taking another product, like something for depression, where women may disproportionately be taking those products. So I think there are a number of things that we're now learning and that we're looking at, and I think that we'll be able to improve our numbers more and more.
This is Dr. Clayton. I would certainly echo the FDA's perspective. We find that women will participate, but there are a variety of factors that may affect the rates of participation. The other point I want to add is that even older women will participate. The WHI, the Women's Health Initiative, had participants up to the age of 80, and there were several strategies and approaches that were demonstrated to work for a variety of diverse populations of women of all ages. And so attention to those issues from the beginning is something that's really important, to make sure that you ascertain the population that you're seeking in a clinical study.
And just to remind, this is Nancy Lee, just to remind that women won't participate unless they're asked. And so many, many clinical trials begin with the health provider making the suggestion to participate. So that's where those of us in the health profession can really help.
Wonderful. Thank you so much. The next question is, how is your office making sure women get coverage under the Affordable Care Act?
This is Nancy. I can talk about that because we've spent a lot of time in the Office on Women's Health here at the Office of the Secretary in that topic. And this is a major push throughout HHS, as you know. We have as I mentioned in my opening remarks, we have a very large website and social media presence, and we've actually been working with CMS to develop several campaigns. One last year targeted women who were mothers of adult young uninsured people, say between less than 20 to 35 or so, to encourage those mothers to get their adult children covered, because we know that adult children are more likely to listen to their mother on advice like this than anything else. So we had that campaign. This year we've we did a social media campaign using primarily Facebook, Pinterest, and Twitter to reach out to young women about getting covered. We've also funded some of our existing grantees and given them additional funds to support Navigator and assister programs so that these poor and often uninsured women who are kind of left off and not really experienced with having insurance can learn how to enroll and then use their insurance. So this is some of the ways that we have in our office been working to get women covered, because we know how important this is for the health of women across this country.
Wonderful. Thank you so much. Another question posed to the panel is, what is the role of pharmacological companies in funding and supporting research for testing of drugs used in clinical trials related to women?
Well, as I indicated earlier, FDA accepts applications from sponsors. The sponsor's role is to develop the concept as well as submit to FDA the information and background before they begin a trial on human subjects. So they have a huge role in the actual discovery and development of the product, and of course they do that collaboratively, frequently funded by NIH grants as well. And then of course all of those discoveries have to come through FDA for review before they go on to the market.
Wonderful, thank you. Another question for the panel. Besides reproduction, are males and females really that different?
This is Dr. Clayton. So, you know, men and women, males and females, are different from head to toe. The important point is we need to look for those differences. Sometimes, for example, the way a disease might present, as you heard from Dr. Lee, heart attack, for example, the symptoms that a man and a woman may have may vary. The diagnostic tests used to detect coronary artery narrowing may be more sensitive or more specific. That is, they may work better in a man as opposed to a woman because the pattern of disease is different. Men and women are that different, and if you don't look, you certainly don't know. And at the basic level, in terms of whether the lung cells of a woman, for example, are different from the lung cells of a man, we now know through scientific technologies that even at the level of the molecule where genes are being expressed, that there are differences between males and females. Now the point there is to understand when those findings, when those differences are scientifically relevant and how they are clinically important. So we would like to be able to make sure that sex as a biological variable is examined, and we compare and contrast so we know about similarities and differences across the board from the basic level to the clinical level.
Wonderful, thank you. The next question for the panel, are there any plans to require drug companies to include a certain percentage of women or people of color in clinical trials? And if not, what can we do to incent drug companies to include greater proportions of these important subpopulations?
This is a very critical issue for FDA because one of the things that we have to ask is, what is enough? Many of our advocates would like to have 50% women, for example, in every clinical trial. And the reality is that may not happen. So we do have to have a minimum number, and we're trying to ascertain on a product-by-product basis exactly what is that. We will be convening with the center, meaning the Office of Women's Health at FDA, will be convening a meeting later this year with the Center for Drugs to bring in industry and investigators to talk about the methodologies that are currently being used and if they are sufficient. One of the things that we're going to try to do is to come at it from a variety of vantage points. Every one of our stakeholders has a role. Health professionals have a role to encourage women to participate. industry has a responsibility to assure that their trials look like the end users. And FDA has a responsibility to look at the methodologies that are being used. So we're going to try to also encourage women themselves as individuals to be more knowledgeable. And as I think I indicated at the end of the year, it is our hope that our office with Dr. Clayton's office will launch a campaign to inform laywomen about how they can volunteer for clinical trials that are appropriate to their needs.
Wonderful. Thank you so much. We've had several questions posed, but this is the general gist of it. What measures are being taken to address trust in recruiting women, especially women of color, given the past medical abuses that occurred in this population, such as forced sterilization and the Tuskegee trial? Panel?
One of the things that I'll call to your attention is pharma itself, the association responsible for representing drug companies, has a major initiative called I'm In. And what they are doing is trying to go to communities of color as well as universities and institutions that treat them to encourage greater participation. FDA has, in conjunction with NIH, certain safeguards that did not used to exist years ago when many of these atrocities occurred. And so we do have IRB and risk requirements where there are standards as well as consent surveillance around how patients are treated. And anyone that has a concern about this now has opportunity to report anything that is of concern or questionable ethics. But I think we have much better safeguards than we used to have, and that's one of the things we need to do is to start educating women that some of their concerns are certainly valid, but things that hopefully we have moved past and put in safeguards to avoid in the future.
Dr. Clayton, I'll just also add that the whole notion of community-based participatory research really is not a new concept. It's been around for some time, but involving community members in the design and reporting and conduct of research is another strategy that some federal agencies have employed. And as Marcia Henderson mentioned, there are a lot of safeguards that are in place that were not in place in the past. Clearly, it is important for there to be diverse populations involved in every stage of the research, the biomedical research enterprise. And so expanding that is a partnership and is certainly something that we all work together on.
Wonderful. Thank you so much. Another question, another topic. Can you talk a little bit more about the progress HHS has made in helping get early diagnoses for breast and cervical cancer?
This is Nancy. There's been a lot of work, I think, across all of HHS over the last 30 years. Certainly it began with the understanding and the funding for research around what were the best methods of screening, for example, screening and early detection for particularly for breast cancer, but also more recently newer methods to screen for cervical cancer. And then as Marcia mentioned in her remarks earlier, the Mammography Quality Standards Act, which came out in the early 90s, set up a very important process to regulate and assure the overall quality of mammography across this country. In 1991, Congress passed the National Breast and Cervical Cancer Early Detection Act, which created a process run out of CDC to fund all 50 states and tribes and territories to provide mammography and pap smear screening for poor and uninsured women, and that grew rapidly and has been a very successful program and a safety net. Out of that program also came the Breast and Cervical Cancer Treatment Act in about 2000, which provided uninsured women with assured treatment for their diagnosed breast and cervical cancer. And then I do not want to, although it's not related to detection, but certainly the incredible advances in treatment for breast cancer has played a huge role in the decline in mortality from breast cancer. There's still disparities and places we need to work on, but we've come a long way.
Wonderful, thank you. I think we have time for about one or two more questions. For the panel, I hear a lot about recruiting participation from minority communities, but what about the researchers being committed to bring results back to the community and inform communities?
This is Dr. Clayton. I can address that from a perspective of the biomedical research workforce. As the question suggests, it's critically important for research results to be disseminated as broadly as possible, but it's also important for the investigators and those on a research team to be as diverse as possible. To that end, NIH has established a new position called the Chief Officer for Scientific Workforce Diversity, and Dr. Hannah Valentine is the first COSWAT, or Chief Officer for Scientific Workforce Diversity, and reports directly to the NIH Director. Dr. Collins set up several advisory committee to the director working groups to address these issues. We clearly have a problem in terms of a lack of diversity in the biomedical research workforce, and a biomedical research workforce that doesn't mirror the diverse populations in the United States and our future. So from that perspective, NIH is committed to addressing these issues through this Chief Officer for Scientific Workforce Diversity, as well as a variety of other funding opportunity announcements that have been released in the last several years. In terms of disseminating research results to the public, that is something that NIH takes very seriously, and through our Office of Communications and Public Liaison, works hard to develop content in a variety of languages, in a variety of formats, using various media to disseminate that information to the public. And I want to highlight one that I'm particularly proud of, and that is our Women of Color Health Data Book. In this data book, we talk about findings in women of color. All of us are not the same, and certainly all women of color are not the same, but we have particular health concerns and health issues. And that information is disseminated broadly, and I encourage our listeners to take a look at that at our website as well. But those are a few of the things that we're doing from the research funding and the biomedical workforce perspective.
Wonderful. Thank you so much. I'm afraid that is all the time we have for questions today. For the questions that have not been answered, we will summarize the questions, and we will develop a FAQ that we will also be posting with the archived presentation of this webinar, as well as the slides on the Public Health Reports website. There's been several questions about where to go to receive these slides and the archived presentation. If you go to www.publichealthreports.org, there will be a tab at the top for webinars. And it should give us about 5 working days to have the full webinar posted with the archive, as well as the slides, as well as the FAQs. Thank you very much. Dr. Shaw?
Well, thank you all for joining us today, and a special thank you to the speakers and their staffs for their time and contributions to this webinar on a hugely important public health topic. I also want to especially thank Erin Williams and the Association of Schools and Programs of Public Health for expertly managing this webcast. And thanks also to the Office of the Surgeon General for its continued support. A reminder that anyone seeking a credit for certification in public health continuing education practice, you will need a password for the credit. The password for this webinar is progress. That's progress. That's the password. So this is the end of the Public Health Reports Meet the Author webinar. As a reminder, this webinar will be archived on the PHR website for future viewing at publichealthreports.org. Thank you, everybody, and good afternoon.